Hello everyone, in this video we are going to take a look at preterm labor. So this is a very important topic both in theory as well as the practicals. So let's begin. Premature or preterm labor. A definition. It is defined as the onset of labor before the completion of 37 weeks of gestation, 37 weeks from the first day of the last menstrual period. It is significant cause of perinatal morbidity and mortality. In developing countries, the lower limit of gestation is considered to be 28 weeks. So we need to keep both of these things in mind, 37 weeks as well as the 28 weeks mark, because both are essential. And coming to the causes of preterm labor, it is divided into history related factors, complications in present pregnancy, iatrogenic causes and idiopathic causes. And now let's look at each of them one by one. First one, history related factors. Previous history of induced abortion or preterm delivery, assisted reproductive techniques, asymptomatic bacteriuria or recurrent UTI, smoking habits, low socioeconomic and nutritional status, and maternal stress. So all of these things could be elicited in the history. Again, previous history of spontaneous induced abortion or preterm delivery, ART, UTIs, smoking, socioeconomic and nutritional status, and maternal stress. So now coming to the complications in present pregnancy. So there are maternal causes, chronic diseases, genital tract infections, fetal factors and placental factors. So maternal causes, pregnancy complications like preeclampsia, APH, premature rupture of membranes, polyhydramnios, and uterine anomalies like cervical incompetence, malformation of uterus. Coming to medical and surgical conditions, acute pyelonephritis, diarrhea, appendicitis, toxoplasmosis, and abdominal surgeries. So all of these pregnancy complications, uterine anomalies, and medical and surgical conditions, all of these contribute to the maternal causes. Chronic diseases like hypertension, diabetes, heart diseases, nephritis, severe anemia, and periodontal disease. So all these come under chronic. And coming to genital tract infections, bacterial vaginosis, beta hemolytic streptococcus infections, chlamydia, mycoplasma. So specifically this one and chlamydia both are important, and we have covered it in the gynec section. Coming to fetal factors, multiple pregnancies, congenital malformations, intrauterine fetal death. And so intrauterine fetal death contributing to preterm labor. Let's not forget the topic at hand, the heading. Finally coming to the placental factors, infarction, thrombosis, placenta previa, and abruption. So all of these can lead to preterm labor. So before we go on, let's finish this, then I have something to say. Iatrogenic causes indicated preterm delivery due to medical or obstetric complications. So based on the complications, there could be preterm delivery. And idiopathic causes, most of them fall under this. Premature effacement of cervix, irritable uterus, early engagement of fetal head, or without any kind of underlying pathology. So let's copy all of this, the preterm labor, and wait a second. So these are the causes of preterm labor, right? So let's copy all of this and let's go to ChatGPT, and we need something like a principle. I'll type it here for you to understand it better. So these are the principles, these are the causes. Causes of preterm labor. Give me some principles to understand how these lead to PTL. So let's get some pathophysiological understanding. Uterine overdistension, polyhydramnios, multiple pregnancy, uterine anomalies. So these cause stretch, and this triggers mechanical stretch, stimulating myometrial contractions and premature cervical changes. Coming to inflammatory response and infection. So genital tract infections, all of these activate inflammatory cascade, so that can also induce premature labor. Inflammatory cytokines stimulate uterine contractility, leading to premature rupture of membranes. placental dysfunction and ischemia, abruption, infarction, thrombosis, placenta previa. So all of these lead to preterm contractions. Then coming to preeclampsia, release of anti-angiogenic factors, again inflammation and preterm labor. In cervical insufficiency, this makes sense. Premature remodeling, so this leads to early effacement and dilation. So in this particular case, matrix metalloproteinases can lead to this particular thing. Next, coming to endocrine and hormonal dysregulation. So maternal stress, chronic diseases, diabetes, hypertension, smoking, all of these can activate HPA axis and can lead to preterm labor. And cortisol catecholamines can also increase the contractility and prostaglandins. Iatrogenic and medically indicated factors ensure maternal and fetal survival at the cost of prematurity. So this is a decision that is being made by the physician. And finally, idiopathic, can't exactly tell, but overall it's a mix of uterine irritability, cervical shortening and immune or endocrine factors. So we have understood how each of these etiological factors can contribute to preterm labor. It's overdistension, irritability, inflammatory, mainly in that particular section what we are thinking about. Next, coming to predisposing factors, clinical biochemical markers that indicate an increased risk of preterm labor. So there are clinical predictors, biophysical predictors and biochemical predictors. Biochemical. So first one, clinical: prior history of preterm labor, multiple pregnancy, presence of genital tract infections and symptoms of preterm labor. And then there are biophysical predictors like contractions, score and cervical length. So first one, uterine contractions greater than 4 per hour, Bishop score greater than 4, greater than or equal to 4, cervical length less than or equal to 25 millimeter. So these are some numbers for biophysical predictors. Then coming to biochemical predictors, fetal fibronectin in cervicovaginal discharge greater than 50 nanogram per ml, elevated cytokines IL-6, IL-8 and TNF alpha. So these were the predisposing factors. We saw clinical predictors, biophysical predictors and biochemical predictors. In this one we got some information from the history. In this one we got some numbers, physical and biochemical, we got some chemical mediators and also these things, fibronectin greater than 50 nanogram per ml. Next, coming to relevant investigations, clinical assessment, laboratory investigations and imaging. So clinical assessment, regular uterine contractions with or without pain, at least one in every 10 minutes. Regular uterine contractions with or without pain, at least one in every 10 minutes. Cervical dilatation greater than or equal to 2 centimeters and defacement 80% of the cervix. So that is seen. Clinical cervical dilatation and defacement. Cervical length by TVS less than or equal to 2.5 centimeters. So overall what we are looking at? So we are looking at the first stage of labor in this particular case. So uterine contractions and cervical dilatation, cervical length, pelvic pressure, backache and vaginal discharge and bleeding. Overdiagnosis is preferred and over underdiagnosis. So better to know than to not know. This one is the case with most of the things, right? Except in case of bacterial infections where you don't want to give the antibiotics unnecessarily. Yes, I can't think of anything else. Yeah, so clinical assessment mainly is looking at the first stage of labor, and here there is something extra like pelvic pain, pelvic pressure, backache, vaginal discharge and bleeding, overdiagnosis and better over underdiagnosis. Next, coming to lab investigation, full blood count CRP, urine analysis, culture, sensitivity to rule out UTIs, cervical culture for group B streptococcus, chlamydia, mycoplasma, fetal fibronectin in cervicovaginal secretions. Next, coming to serum electrolytes and glucose levels. So again, full blood count, CRP, some things for UTI. So first one was for inflammation, second one is for UTI, next one again for infection, next one is for fetal fibronectin. Let's take a look at what this thing means. Fetal fibronectin in PTL. Fetal fibronectin is expressed as MMP. Yeah, it is an MMP. So positive test indicates preterm labor. And serum electrolytes, glucose levels. So this is electrolyte and glucose, which is something different. Coming to the imaging, transvaginal ultrasound for cervical length and Doppler ultrasound for fetal well-being and placental circulation. Finally, coming to the management of preterm labor, labor at 32 weeks with intact membranes. So there are general principles, interventions, and finally we are going to take a look at how we are taking care of the newborn after the preterm birth. So first one, prevent preterm labor if possible. Why? Lung maturity is a problem. Next, coming to arrest preterm labor if no contraindication. So try to stop it. Provide appropriate management of labor and ensure effective neonatal care. Number one, bed rest. These are the interventions. So preferably in left lateral position to minimize the pressure on the cervix. So this is number one. So in case maybe in supine position there is more pressure on the cervix. What if other position? This is not in the left lateral, but different position may have. Lying on the back, IVC compression. Right lateral is fine. Upright, prolonged periods, increase pressure on this one. What is it? The cervix. And Trendelenburg, head down, feet up. It's used in severe cases. Okay, fine. Adequate hydration ensures proper uteroplacental circulation. Prophylactic antibiotics for suspected or confirmed genital tract infections, including group B strep. And yeah, these ones we know the etiological factors for preterm labor. Yeah, so this one is targeting that antibiotics. Then coming to corticosteroids, this one most awaited one, betamethasone, dexamethasone, to promote fetal lung maturity, reducing the risk of fetal distress, fetal respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and patent ductus arteriosus. All these things are tackled with corticosteroids. Yeah, and tocolytic therapy. So we don't want contractions to happen. So short term tocolysis to delay labor for corticosteroid administration 1 to 3 days. And then commonly used agents are for tocolysis, meaning contractions not happening. So you block the action of you block the function of these muscles that contract. You don't want the contractions to happen. So what do you do? Calcium channel blockers, nifedipine, beta agonists, these are terbutaline, ritodrin, magnesium sulfate for neuroprotection under 34 weeks, progesterone supplementation, micronized progesterone vaginal gel. So all these four things contribute to tocolytic therapy. Then coming to neuroprotection, magnesium sulfate, 4 gram IV loading dose followed by infusion of 1 gram per hour for 24 hours. So these this one to reduce the risk of cerebral palsy in less than 34 weeks fetus, newborn that were delivered within 34 weeks. Yeah. Coming to monitoring, continuous fetal monitoring via CTG, ultrasound, ultrasound for fetal well-being and placental assessment. So that comes under monitoring, because we want to know whether it is still live or if there is something fishy going on. Coming to the management, preterm labor before 34 weeks, then late preterm 34 to 37 weeks, and vaginal delivery preferred unless obstetric indications require C-section. So first one, this one, tocolysis recommended unless contraindicated. So do tocolysis for very early 34 weeks. 34 to 37 weeks, expectant management with close monitoring, and vaginal delivery is preferred unless obstetric indications require C-section. So always vaginal delivery. Neonatal care after preterm. So immediate transfer of neonatal ICU to neonatal ICU, that is number one. Respiratory support with surfactant therapy and oxygen therapy. So this particular topic about preterm labor and surfactant therapy is given in much more detail in the pediatric section. So kindly take a look there. thermoregulation to prevent hypothermia, monitoring for hypoglycemia, hypocalcemia and sepsis, early feeding with expressed breast milk or parenteral nutrition if needed. So all of these things are for newborn care after preterm birth. So and finally coming to prognosis, yes, how can we forget this? Preterm labor and delivery of low birth weight baby result in high perinatal mortality and morbidity. That's why we have a separate question here altogether. NICU support significantly improves the survival rate, especially greater than 1 kilograms babies. Surfactant therapy improves the neonatal survival less than 26 weeks. So before going somewhere else, I think we need to look at, no, it's not here. Yeah, there was a section somewhere where it classified the different types of preterm, early preterm, late preterm and all of that. I'll try to include it here in the next one, in the next when I get time, the types of preterm children. Maybe I have discussed about it earlier, I can't actually remember, but in order to not waste more time on this particular video, I'll just leave it there and then include that section here so that you can go through it in the future. And anyways, I'll conclude the video now. In case you like this particular video, you can like it. In case you would want to watch more of such videos, you can subscribe. Bye bye.